Thank you. Thank you so much for the introduction. Let me thanks to the organizer for inviting me to this important meeting. It's a pleasure for me to be here. So my first presentation regards the ELG number 43 trial. This is a randomized trial that compared the role of autologous stem cell transplantation with non-myeloablative chemotherapy in patients with newly diagnosed primary CNS lymphomas. This, so as you probably know, the ELG-32 trial, the previous trial of the International Extranodal Lymphoma Study Group, defined a new standard of care for patients with primary central nervous system lymphomas. This was the first randomized trial showing an improvement in the overall survival of these patients with the comparison of three different chemotherapies. In particular, the use of four drugs, methotrexate, cytarabine, tiotepa, and rituximab, the so-called matrix regimen, was associated with a significantly improved overall survival. Whereas regarding the second randomization of the trial, the comparison of the two different consolidations, whole brain radiation therapy and autologous transplantation, showing similar results. Both strategies are equally effective as consolidations. However, the use of whole brain radiation is associated with higher rates of neurocognitive decline. And then for these reasons, our standard of care in most European countries and other places around the world is matrix for 4 courses, followed by autologous stem cell transplantation. And these are the results of these combinations. However, this is a very intensified strategy, and it is in particular patients over 65 years old are highly selected, need to be highly selected to receive this type of a strategy. Then some years ago we designed a randomized phase 3 trial comparing two different consolidation strategy, the autologous stem cells transplantation versus the non-myeloablative chemotherapy. This trial was conducted in 79 centers in 5 European countries. Progression-free survival was the primary endpoint. This was the key selection criteria. We considered only immunocompetent patients with an age, with a similar age and performance status scores in comparison with the ELG-32 trial, and with at least one measurable lesion. The recruitment was successfully completed in 5 years, between 2014 and 2019. And the design is 4 courses of matrix followed by a randomization between 2 courses of Erdevic. Erdevic is a high-dose ifosfamide-based combination. Obviously, it's a non-myeloablative chemotherapy versus high-dose chemotherapy with carmustine and tiotepa and reinfusion of autologous stem cells. The characteristics of the patient were the same in both arms. There was more than 300 patients that were enrolled, and 115 patients were randomly allocated to receive Erdevic and 114 to receive autologous transplantation. The anagrammics are similar to those of other trials in these populations. From the 368 patients, 346 started the treatment, others were excluded for different reasons, in particular due to staging and diagnosis. And 116 patients discontinued the treatment, in particular due to progressive disease and adverse events. There were 13 patients who did during the induction chemotherapy, in particular due to infection complications. That is, in an international extensive study on 79 centers, the matrix was associated with treatment-related mortality lower than 4%, which is a very encouraging result. So, a few words on the toxicity. The toxicity on the randomized arms were prevalently hematological, with obviously higher toxicity in the transplantation arm, with a higher rate of infections and mucositis, but this is expected with this type of strategy. Importantly, there were 4 additional deaths after autologous transplant, and there were no deaths during and after RDBIC. The responses were very similar. There was 40% of complete remission rate after matrix, and the complete remission rate after the VIC was 65%, and after autologous transplant, 68%. Nevertheless, the progression-free survival was significantly better in patients treated with autologous transplant. Then there was not a lower response, but it was more often long-lasting responses in these patients. In particular, the 3-year progression-free survival after autologous transplant was 79% versus 52% in the non-myeloablative arm. And similar figures can be observed in the overall survival course. The 3-year overall survival was 86%, which is an outstanding result in primary CNS lymphomas after autologous transplant, and 71% after the VIC, with a risk reduction of death of 54%. According to the age of the patients, as you can see, the results were similar in patients younger and older than 65 years. There was not a difference. We confirmed the superiority of autologous transplant with respect to RDBIC in both subgroups of patients. Importantly, there were not a difference in neurocognitive functions. This was monitored in these patients with following the panel of the International Pcnsl Collaborative Group, and as you can see, there was an improvement in mostly of this function, and there was not a difference between transplantation and non-myeloablative chemotherapy. This superiority of autologous transplant was more evident in patients who achieved, in young patients, and in patients who achieved a complete response before randomization. And good results were observed in both subgroups according to the performance status. In summary, this is the largest randomized multicenter phase 3 trial investigating the role of autologous transplantation in patients with primary central nervous system lymphomas. The results, the progression-free survival, the primary endpoint, and the overall survival were significantly better after autologous transplant in comparison with non-myeloablative chemotherapy, despite similar remission rates after consolidation. The neurocognitive improvements were observed in both subgroups, and obviously this encouraged us to improve in particular the tolerability of matrix in order to offer to a larger proportion of these patients autologous transplant after induction. In fact, in Europe there is now an ongoing randomized trial, the Optimate trial, that compare the conventional matrix with a sort of de-escalated matrix in particular during the first course in order to improve safety, tolerability, and then to increase the proportion of patients to receive consolidation. This is only to thank the 79 centers in the different countries that participated in this trial. In particular, my friend Dr. Gerald Irerhaus from Stuttgart, that is my co-chairman of this trial. And thank you for your attention.